All right, good afternoon, everyone, and welcome to Renal Grand Rounds. Today is a very special event. We have a wonderful guest speaker today, Dr. Rupal Mehta, who I think most of you in the audience know extremely well. I'm not going to give too much of an introduction. I think most of you know she's an exceptional physician scientist here at Northwestern. She's currently an assistant professor. She did do her training locally at UIC Med School and then was at University Hospitals at Case in Cleveland for her medical residency, where she was also chief medical resident. And then we were incredibly fortunate to recruit her here for nephrology fellowship in 2012. And she has remained here, did training, and has her master's in scientific clinical investigation, an incredibly successful investigator, being awarded a National Kidney Foundation Young Investigator Award. She received a KL2 award here and is now holding a very difficult to get K award focused on pathogenesis of heart failure with preserved ejection fraction in patients with chronic kidney disease. So, Rupal, without any further ado, I'm delighted, and you're going to tell us and tell me how I can get along with my daughter now with some heart-kidney synergy.
Thanks so much, Dr. Quagg. And if you could tell me how to get along with my husband, who's a heart failure cardiologist, we'll be even then when we talk about this. So thank you so much for everybody coming today and for your attention moving forward. It's really exciting to be here and to kind of present some of my research and some of what I am extremely passionate about studying. So today we'll be discussing heart-kidney synergy and really exploring the role of the kidney in heart failure with preserved ejection fraction. So here are my disclosures, some ownership stock in AbbVie, and then I'm on the Speakers Bureau for AstraZeneca as well. And so here are three concise objectives I'm hoping to kind of portray over the course of the next 45 minutes. I'd like to give a brief overview of the heart-kidney connection as it relates specifically to heart failure. I'd like to explore heart failure with preserved ejection fraction as a heterogeneous disease state or syndrome. And I'd like to tell you a little bit about how our research group and how we are using the metabolome to subphenotype the CKD phenotype of heart failure with preserved ejection fraction. And so let's start really briefly. I think everybody in this room really understands the bidirectional relationship of the kidney and the heart. You know, the patients with chronic kidney disease and patients with cardiovascular disease, specifically heart failure, share a lot of comorbidities, including diabetes, including hypertension, including obesity, and also including kind of the aging phenotype. There's other things as well, such as systemic inflammation, that are very common to both of these disease states. In the literature, especially on the cardiology side, they talk a lot about with kidney disease, as kidney disease progresses, there's a lot of salt and water retention. And I think we all know that there's a lot of other abnormalities that happen in kidney disease as well. But a lot of the focus sometimes is on salt and water retention as CKD progresses, that leads to then a stiff or overfilled ventricle, which then leads to cardiovascular disease, specifically heart failure, whether it be heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. We all know, though, as cardiovascular disease progresses and heart failure progresses, whether it be through reduction in cardiac output or low cardiac output states, whether it be through venous congestion, whether it be related to worsening hypertension or worsening left ventricular hypertrophy, that we know that as CVD disease progresses, that we get renal injury and renal insult, and CKD progresses as well. And then we kind of get into this vicious cycle of cardiovascular disease leading to renal disease leading to cardiovascular disease. And the question always becomes, which ones do we target? Are there therapies that can target one or both? And so here's a little bit of data. You know, when we look at patients with acute decompensated heart failure, on the left there's data from over 100,000 individuals who were enrolled into the ADHERE trial that show that kidney disease is common in patients with heart disease. Almost 80% or 85% of patients with acute decompensated heart failure have either stage 2, 3, or 4 CKD. On the right there's data from approximately 2,000 individuals that show as eGFR declines, there's an increased risk of mortality. The the gold standard for clinical outcomes. And so kidney disease is common, and it increases the mortality in patients with heart failure. But what if we look at it from the other side? What about our patients with chronic kidney disease? So these are data from approximately 3,800 individuals in the chronic renal insufficiency cohort study, a prospective longitudinal study that looks at risk factors for cardiovascular disease and renal disease progression. And what you see is that as eGFR declines from greater than 45 to less than 30, the incidence of heart failure admissions goes up. When you use UACR as a biomarker of kidney function, as UACR goes up, the incidence of heart failure goes up. When you look at eGFR and UACR combined as two biomarkers of kidney disease and kidney function, we see that incidence of heart failure goes up. And so I don't think this is new to anybody, but it's just data that demonstrates that not only was kidney disease common in patients with heart failure, but heart failure is extremely common in patients with kidney disease. And as kidney disease progresses, the risk of heart failure hospitalizations in our patient population also increases. And so when we talk about looking at risk factors for heart failure, when we look at our patients with chronic kidney disease or kidney disease, we see that eGFR is a good marker, but there's lots of data that suggests that UACR is a better marker for incident heart failure or heart failure risk in our patient population. And lots of people proposed different mechanisms, whether UACR is a better marker for endothelial dysfunction or microvascular disease or not. But we see that UACR does add to our risk our risk profile for patients with kidney disease for heart failure. On the right, you see data where they compared UACR to many other, both cardiac biomarkers as well as systemic biomarkers. And you see that UACR is a risk factor for both heart failure with preserved ejection fraction as well as heart failure with reduced ejection fraction. And they define these as LV or left ventricular ejection fraction with a cutoff of 50%. You see that it's actually a better marker than many markers, especially for heart failure with preserved ejection fraction. And this is going to be a common theme throughout, that patients with kidney disease may be at higher risk for HFpEF, or heart failure with preserved ejection fraction, than reduced ejection fraction. Almost as good as natriuretic peptide as well. And you see like BNP, natriuretic peptide, is a very strong risk factor for heart failure with reduced ejection fraction, but not as good as a risk factor for incident HFpEF in comparison to HFrEF. So we looked at this a little bit as well. We know the burden of kidney or heart failure in patients with chronic kidney disease is high, and so the question always becomes in clinics, how do we predict what patients are going to be getting or at risk for heart failure? And when you look at other populations, not the CKD population, so when you look at the general population, there are a lot of validated risk scores for heart failure prediction, and they do quite well. The PCP heart failure risk equation that was developed by Dr. Sadia Khan and Dr. Donna Lloyd-Jones here at Northwestern predicts very well what patients in the general population will have heart failure. And that equation is endorsed by the AHA, it's endorsed by HFSA in terms of predicting heart failure risk. And so we look to see how that equation would do in our CKD population. So these are patients with chronic kidney disease are also enrolled in the chronic renal insufficiency cohort study. And this isn't surprising. We saw that this equation performed pretty poorly in our CKD population. There was a consistent underestimation of events with inadequate discrimination and poor calibration of this equation. The graphs you see are predicted probability on the horizontal axis and observed probability on the vertical axis. And you see these deciles of patients, and you see these dots. They don't match the calibration line at all. They quite underestimate the events. Once again, not surprising, because we know our patients with chronic kidney disease have different things, pathophysiology going on that puts them at risk for heart failure much greater than the general population. When we added UACR, which we know is a risk factor for heart failure, and we added this to our model and we revalidated this equation, we saw much better discrimination and much better calibration. You see those dots are much closer to the lines than they were prior. When we added eGFR to the same equation, we didn't see as good of discrimination or calibration. And when we added eGFR and UACR together, and I don't show you these data, that equation didn't do much better than just adding UACR alone. Once again, suggesting that UACR is a good risk factor or predictor in patients with chronic kidney disease to predict what patients will get heart failure. I don't think this is surprising to the group in this audience, but it's not UACR outside of renal clinics sometimes is not measured very often. Mm-hmm. Absolutely.
How do you include the UACR as a continuum
It was
by stages or just
It was a continuous variable when we added it to, when we included it in the tenure risk equation. It was used as a continuous variable. The other nice thing about this equation that Dr. Khan and Dr. Jones, made were this equation, when they made it so it was very clinically useful to primary care providers and clinicians. It used no echo variables, it used no MRI variables, which many of our patients don't have. It used very clinically relevant variables: age, sex, cholesterol, hypertension, diabetes, smoking status, QRS duration on ECG. And then we added UACR, revalidated the entire equation, revalidated the equation using UACR as a continuous variable, as well as EGFR as a continuous variable. It seems so, and this data is consistent in literature. It's not just this. These are some supporting data, but there's data that are very consistent that UACR is a good predictor of heart failure events, better sometimes than EGFR alone. And we see this commonly where we see before reductions in glomerular filtration rate in our patients, we see proteinuria sometimes prior to changes in GFR. And so whether it's an early predictor, whether it pathophysiologically does something differently or represents something differently is also, proposed. So, when we look at our patients with chronic kidney disease, and you look at echocardiographic findings in our patients with chronic kidney disease, it's not, surprising that we see that about 70 to 80% of our patients with stage 2, 3, 4, 5 CKD have left ventricular hypertrophy. So these are data from Nisha Bansal at University of Washington that looked at echocardiographic findings in patients with moderate, advanced, and end-stage renal disease. They defined moderate CKD as an EGFR between 20 and 60. They defined advanced CKD as an EGFR less than 20, and they defined end-stage renal disease as patients on hemodialysis or peritoneal dialysis. And like I said, about 70 to 80% of these individuals with EGFR less than 60 have left ventricular hypertrophy on their echocardiograms. What's more surprising, I think, maybe, is if you look at the line on left ventricular ejection fraction, regardless of moderate, advanced, or end-stage renal disease, the ejection fraction in all of these groups, or the mean ejection fraction in all of these groups, was greater than 50%. So preserved ejection fraction. If you go to look at the line where it says ejection fraction less than 50%, only 20% of individuals, or 21% of individuals had an ejection fraction less than 50%. It does go up with end-stage renal disease. Most prior literature has suggested that patients who have preserved ejection fraction don't transition to having reduced ejection fraction over time because the pathophysiology of heart failure with reduced ejection fraction is very different than the pathophysiology of heart failure with preserved ejection fraction. However, the CKD population might be a little bit different because we know as CKD progresses, there's other alterations that may put patients at risk for reduced ejection fraction, primarily in the end-stage renal disease population of myocardial ischemia and infarct, especially on those on hemodialysis. If you look, consistent with this is if you look at their LV geometry, you see regardless of moderate, advanced, or ESRD, that approximately 70% of individuals in each group have concentric remodeling or concentric hypertrophy, all putting patients at risk for heart failure with preserved ejection fraction. When you see eccentric hypertrophy, that puts patients at risk for reduced ejection fraction. All of these data are consistent, that patients with CKD have echocardiographic findings that put them at risk for heart failure, and the type of heart failure that they put them at risk for is actually heart failure with preserved ejection fraction over heart failure with reduced ejection fraction. These are also data that kind of show very similarly the same thing. As EGFR declines, you see an increasing rate of concentric hypertrophy, all putting patients again at risk for heart failure with preserved ejection fraction. And so what within CKD puts our patients at risk for heart failure? And I talked about salt and water retention. That's written in the literature a lot because that's what we see clinically, volume overload. But there's lots of other abnormalities outside of the common comorbidities that we think of, like diabetes and hypertension, but a lot of other abnormalities that happen in kidney disease that could put patients at risk for the development of left ventricular hypertrophy, for cardiac remodeling, and for then clinical heart failure. And this could be abnormalities in mineral metabolism that lead to vascular and valvular calcifications. It could be systemic inflammation that happens early in the setting of chronic kidney disease and just gets worse as kidney disease progresses. And then there's some data that proteinuria in itself may be pathologic. I'm not sure there's good data on that by any means, but more probably a representation of microvascular disease that happens as kidney disease progresses. And so we'll go through very briefly a few of these. So alterations in mineral metabolism, my other passion in terms of research, have been linked to heart failure as well. So these are data from now, almost 15 years ago, 17 years ago, that show as serum phosphate levels rise, there's an increasing risk for cardiovascular disease, including heart failure. You see a linear rise with the risk of all-cause death, coronary death or non-fatal MI, fatal and non-fatal MI, as well as heart failure as serum phosphate increases. I will say the caveat to this was these data were prior to the exploration of FGF23 in the literature and measurement of FGF23 in the literature. When we look at FGF23 or fibroblast growth factor 23, it's an osteocyte-derived hormone that helps regulate vitamin D and phosphate metabolism, and we know that rises as kidney disease progresses. And we see here very clearly that FGF23 rises. We see an increasing risk of congestive heart failure as well as left ventricular hypertrophy. The data I don't show you here is that in the echocardiographic findings with FGF23, there's also an increased risk of FGF23, once again with concentric remodeling or hypertrophy. Also, once again, putting us at risk for heart failure with preserved ejection fraction. These data are from the chronic renal insufficiency cohort study that all showed that had kidney disease stages 2 to 4. Other things that kind of are abnormal in patients with chronic kidney disease are things like iron deficiency, which happens early in kidney disease, as well as anemia. And we looked at this in a paper we published last year, and we looked at the risk of iron deficiency in cardiovascular and renal outcomes. And we measured this in approximately 3,800 individuals in the chronic renal insufficiency cohort study again, and we divided our patient population up by quartiles of TSAT and quartiles of ferritin. And we defined iron deficiency as the lowest quartile of ferritin and the lowest quartile of TSAT as well, or transferrin saturation. And we show that individuals with iron deficiency are at an increased risk of heart failure hospitalizations with a hazard ratio of 1.34. This was after multivariate adjustment of numerous covariates. We also saw that individuals with iron deficiency are at an increased risk of mortality. So once again, something in the CKD milieu that puts us at risk for cardiovascular events, specifically heart failure. What I'm not showing here is we went on to show that some of this risk was mediated by elevated FGF23 levels because there's an interaction or a synergy between iron deficiency and upregulation of FGF23. But once again, something in the CKD milieu outside of just salt and water retention that puts us at risk for cardiovascular events. And so, when we talk about what cardiovascular events, and I talked a lot about concentric remodeling and concentric hypertrophy and the risk of heart failure with preserved ejection fraction, well, Alex Leidner, who's sitting in this audience right now, is leading a project right now looking at patients with chronic kidney disease in the CRIC study and looking at HFpEF versus HFrEF incidence. And this is a graph showing cumulative incidence of the different types of heart failure subtype, including heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, and then heart failure with unknown ejection fraction. Patients who had heart failure hospitalizations, but we don't have actually ejection fraction values on them. And he shows that there's higher rates of HFpEF in our CKD population than HFrEF over time. The interesting thing, and I think this is where there's a lot of research that needs to be done, is this heart failure with unknown ejection fraction. Tells us again, though, even though we have robust studies like the chronic renal insufficiency cohort study, right, with a numerous amount of covariates, numerous longitudinal follow-up time, adjudicated events, there's so much data that is still missing, right? We don't phenotype our patients with kidney disease very well, maybe as well as other studies do or smaller studies do, because there's still, a large proportion of patients who had heart failure hospitalizations who we don't know what their EF was. And that's unfortunate in these cases. So I talked a lot about HFpEF versus HFrEF, and so let's dive deeper into HFpEF, because it seems like, and I hope I've convinced you, that our patients with chronic kidney disease are at risk for heart failure with preserved ejection fraction. And so what do we mean by heart failure with preserved ejection fraction? Well, so this diagnosis really rests on the presence of signs and symptoms of heart failure and having a normal left ventricular ejection fraction. But the truth is, it's not all about ejection fraction. These two disease states, heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, are very two different disease states and disease syndromes. Heart failure with reduced ejection fraction is characterized by what we think is myocardial injury, whether it be through myocardial infarction, whether it be because of viral cardiomyopathy, cardiotoxicity, other genetic abnormalities. And it's very much characterized by activation of the neurohormonal system. And we know this because by blocking the neurohormonal cascade, we've seen improvement in heart failure with reduced ejection fraction outcomes. But that's very different than heart failure with preserved ejection fraction. There's this idea that heart failure with preserved ejection fraction really is kind of a secondary manifestation of a peripheral insult. And what I mean by a peripheral insult is a comorbidity disease state that can then lead to myocardial dysfunction. And many people believe that kidney disease may be that peripheral insult that leads to this syndrome of heart failure with preserved ejection fraction. There's a interesting editorial, and this was now probably done almost 10 to 15 years ago by James Fang in Circulation, where he calls HFpEF really a kidney disorder. And so I think this is what we are trying to study in our group, is what is this disease syndrome and what is the role of the kidney in the development of heart failure with preserved ejection fraction. The trouble with HFpEF or HFpEF syndrome is a uniform definition is sometimes difficult, because unlike heart failure with reduced ejection fraction, there's a lack of a single objective marker. We know that ejection fraction, may be preserved, but there's lots of other abnormalities that can happen in the cardiac myocardium that can then lead to cardiac dysfunction. And there's also a high rate of comorbidities, which makes HFpEF a very heterogeneous state. BNP values are also very low sometimes in HFpEF, and traditionally BNP levels are very high when we think of heart failure exacerbations, heart failure admissions, and they're typically low in HFpEF. There's also limited predictive values of things like ejection fraction, and then there's underuse of functional testing or cardiopulmonary exercise testing, and we'll get to that in the next few slides on why exercise testing for the diagnosis of heart failure with preserved ejection fraction is so important. And so when we talk about this HFpEF syndrome, what happens from a cardiac pathophysiology standpoint? Well, we know there's abnormal LV diastolic stiffness and relaxation. We see that there's increase in LV filling pressures at rest, but especially during exercise. There's impaired myocardial LV contractility and systolic mechanics. There's symptoms of dyspnea, lung gas exchange abnormalities, impaired aerobic capacity, and pulmonary hypertension. There's a limitation in systolic reserve when exercising, which then leads to elevated left ventricular filling pressures, and then the inability of the heart to augment its stroke volume and cardiac output, especially during exercise. And then there's this impaired chronotropic response to exercise. So a lot of these things have to do with exercise. So somebody who's at risk for heart failure, let's say a patient with chronic kidney disease that we see in clinic, who has no clinical symptoms of heart failure at rest, but they'll tell you when they walk a lot or when they go up a flight of stairs, they have exercise intolerance. They have peripheral muscle weakness or skeletal muscle fatigue. And that is a clinical sign of heart failure with preserved ejection fraction, because a lot of these abnormalities are actually revealed during exercise and don't happen at rest. And so many of our patients with chronic kidney disease may be underdiagnosed actually with heart failure with preserved ejection fraction, or subclinical heart failure for that matter. And so when we talk about this heart failure with preserved ejection fraction syndrome, we talked about the cardiac manifestations or the cardiac pathophysiology. But what about this peripheral insult? What's happened everywhere else? If we think that cardiac pathophysiology may be a secondary insult, what's happening everywhere else in the body? And so there's this idea that there's the systemic vascular pathophysiology idea, that there's increased systemic vascular resistance with exercise, especially in our patients who have arterial hypertension. There's skeletal muscle pathophysiology, which means reduced capillary density. This has been looked at. Increased intramuscular fat, resulting in reduced utilization of oxygen in tissues. There's pulmonary pathophysiology, which is left atrial remodeling, resulting in pulmonary hypertension, an increase in pulmonary vascular resistance. There's adipose tissue pathophysiology, so obesity, we know, is a huge risk factor for heart failure, preserved ejection fraction. It leads to plasma volume expansion, exaggerated cardiac remodeling as well. And then there's this renal pathophysiology, venous congestion, inability to excrete a sodium load, changes in the renal microcirculation, and volume expansion and systemic inflammation. And our patients, especially with chronic kidney disease, are likely obviously to have the renal pathophysiology, but they may also have these other things happening as well. Many of our patients have diabetes and obesity, so they may have abnormalities in these other peripheral organ systems as well, which is maybe why our patients are at such high risk for heart failure with preserved ejection fraction. So Sanjeev Shah looked at their Northwestern heart failure preserved ejection cohort, and this has now been about 7 years since it's been published. And they use these machine learning algorithms to really look at HFpEF as a syndrome and to figure out what qualities or characteristics do these patients with heart failure preserved ejection fraction have. And this is this heat map, and you see on the right all of these variables. They use echo variables and MRI variables and clinical variables and blood and urine markers. And you see it's a very heterogeneous state. There's not one color that represents the entire box, right? These patients are quite different. Once again, leading to the fact that this is not just one disease state. It's a syndrome that can have lots of different pathophysiology disease states that lead to this syndrome. When they looked at this and when they used these machine learning algorithms, they came up with 3 clusters of groups. And they came up with 3 different phenotypes of patients who have heart failure with preserved ejection fraction. Phenogroup 1 was young, and they had very low BNPs. Phenogroup 2 were patients who were obese, who had diabetes. And phenogroup 3 were patients with chronic kidney disease, who had pulmonary hypertension, who had high BNP values. And when they looked at these 3 phenogroups and looked at outcomes for them, they realized that phenogroup 3 were at greatest risk for having outcomes such as heart failure hospitalizations, cardiovascular hospitalizations, non-cardiovascular hospitalizations, as well as death. And this phenogroup 3 was at greatest risk for mortality as well. Once again, not maybe surprising to the people in this room, right? We know our patients with chronic kidney disease have numerous comorbidities. We now know that they have numerous abnormalities, not just salt and water retention, but other abnormalities that put them at risk for heart failure, and probably put them at risk also for cardiovascular and non-cardiovascular death as well. So when we look at this now CKD subphenotype of HFpEF, right, we take this phenogroup 3 that have CKD, what puts them at risk? Well, we've talked about this, shared comorbidities, vascular changes, neurohormonal changes, systemic inflammation, mineral metabolism, all put our patients with chronic kidney disease at risk for heart failure with preserved ejection fraction. When they've looked at cardiac mechanics of these patients with CKD and heart failure or preserved ejection fraction, you see on the left is conventional 2D echocardiogram tissue Doppler velocities of the left ventricle. And on the right, the 3 right panels are 2D STE parameters. 2D STE, or speckle tracking echocardiography, looks at myocardial deformation patterns that happen prior to clinical changes in ejection fraction. So they look at left ventricular longitudinal strain, right ventricular free wall strain, left atrial reservoir strain. All these parameters are looking at subtle changes of the cardiac myocardium that happen that can lead or predispose patients to heart failure pathogenesis. And what they saw is as CKD progresses from early stages of stage 1 and 2 to stage 5, all of these parameters were abnormal or got worse. Okay, showing that there's early changes in these patients, or changes in these parameters in patients with CKD and heart failure. So we wanted to look at the same patient population, but patients without clinical heart failure, without a diagnosis of heart failure, right? Just our patients without clinical heart failure, with preserved ejection fraction, what do their cardiac mechanics look like? So we looked at this in the cardiovascular health study. It's about 3,500 individuals. And we looked at patients with CKD and without CKD, and we defined CKD as having eGFR less than 60. And all measures of cardiac mechanics, whether you looked at left ventricular mechanics, left atrial mechanics, right ventricular free wall mechanics, measurements of diastolic dysfunction, or left ventricular filling pressures, every marker was worse in patients with chronic kidney disease. Mind you, these are patients that don't have cardiovascular disease, don't have clinical heart failure, but all have worse cardiac mechanics, meaning subtle changes in their cardiac myocardium compared to their non-CKD counterparts. If you look at the CKD patients specifically, the 1,000 patients of this group that just had CKD, about almost 90% of them had an absolute left ventricular global longitudinal strain of less than 18%. Well, what does that mean? 18% sometimes is our cutoff where we say that they have these early changes in left ventricular function that can predispose patients to heart failure. So let me say that again. 90% of our patients in this patient population who don't have clinical heart failure, who don't have cardiovascular disease at baseline, had changes in their cardiac mechanics that would be suggestive of heart failure with preserved ejection fraction, or at least put them at risk for developing heart failure with preserved ejection fraction. When we look at these patients and we look at these different strain parameters in multivariate analyses, and this is all statistical analyses, we see that all of these, or 5 out of these 6 parameters, was associated with prevalence of chronic kidney disease. This is in the entire population. And then further, when we look at these parameters and we say, well, what are the risks of our patients with CKD having a decline in kidney function? These parameters, specifically the parameters that were associated with diastolic dysfunction, early diastolic strain rate, E to E ratio, which is a marker of left ventricular filling pressures, as well as left atrial reservoir strain, were all associated with a 30% decline in kidney function. Once again, showing the bidirectional relationship of kidney and heart disease. Not only are these parameters abnormal in patients with kidney disease, but having these abnormal parameters puts you at risk for a decline in kidney function over time. So I like that this is from a research priorities letter that was published in 2020 about HFpEF, and they talk about these heart failure with preserved ejection fraction predisposition phenotypes, right? There's this obesity phenotype, there's this systemic vascular resistance or arterial hypertension phenotype, there's this renal phenotype, and then there's these clinical presentations as well. I only put this because I want to focus on this renal phenotype or predisposition phenotype of HFpEF, and you look at what the treatment strategies are, and you see ultrafiltration. At every point, ultrafiltration, which is great. This is what we get consulted on the wards for, right? Decongestion therapy, diuresis, how do we get them not to be volume overloaded and out of the hospital? But the truth is, we know, and I hope I've convinced you of this, that there's numerous other abnormalities that happen in kidney disease that predispose our patients to heart failure with preserved ejection fraction. And can we target these other things that are happening in kidney disease, not just get them decongested and not just get them diuresed, but can we target these other things to prevent them from having heart failure hospitalizations or prevent them from developing heart failure with preserved ejection fraction? And I think this is where there's a gap in the literature and there's a gap in our knowledge, because this was just published 2 years ago. And like I said, the role is just diuresis, right? But we know there's more. And now there's more therapies that are coming out that target both the renal and cardiovascular systems to hopefully prevent cardiovascular disease events. But we don't know the mechanisms of how those disease therapies completely work yet. So this is a little bit of what we're studying as well. Outside of the data I've showed you, we're really looking at mechanisms of heart failure pathogenesis in patients with chronic kidney disease. And so right now we're focusing on the metabolome and the intersection of metabolism, CKD, and heart failure with preserved ejection fraction specifically. And so the metabolome, it's highly dynamic. You can understand it as the functional consequence of the genome. It provides information about the biology in a specific time and place. It's proximal to disease phenotype. Metabolites are modifiable, whether it be through diet, whether it be through medication, and thus amenable to therapeutic targeting as well. There's some drawbacks of studying the metabolome as well. And metabolome differs throughout the body. Different organ systems and different tissues, if you measure metabolites in them, they result in differing results. And there's heterogeneity even within an organ system. So if you look at the kidney glomerulus versus endothelial cells versus tubular cells, they may have different metabolites there as well. We're using a very shotgun approach. We're measuring metabolites in circulation. And so we're using when we measure the metabolites in circulation, it's really a accumulation of all the processes that are going on in the body at a given time to really see the changes that happen in CKD. And there's pros to that, but there's also drawbacks to that as well. So when we study the metabolism, our group is really focusing on acylcarnitines. So what are acylcarnitines? Acylcarnitines are intermediates of fatty acid oxidation, and then in the setting of mitochondrial dysfunction can represent byproducts of incomplete fatty acid oxidation. Well, why are we focusing on acylcarnitines? So there's data that shows dysregulation of fatty acid metabolism in mitochondria is linked to heart failure. And there's data that show that levels of circulating acylcarnitines increase across the spectrum of clinical heart failure. So if you compare patients without heart failure to patients with heart failure, there's changes in levels of systemic acylcarnitines. And there's also data that if you reconstitute cardiac output, whether it be through mechanical support or otherwise, you could actually lower the level of acylcarnitines and improve end organ perfusion, and you can modulate systemic and myocardial bioenergetics. So these are the data from from heart failure. They looked at heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and controls. And they saw levels of acylcarnitines much higher in patients with heart failure than without heart failure controls. And the mechanisms are still unclear, but there's a lot of proposed mechanisms of how high levels of acylcarnitines can lead to heart failure signs, symptoms, and incidence. And whether it be through inflammation, cellular stress, metabolic inflexibility, there's changes to the myocardium as well as the periphery that can lead to diastolic dysfunction and impaired peripheral perfusion and oxygen extraction. So there's this idea that long-chain acylcarnitines are elevated in heart failure, and that could lead to or have direct mechanisms to heart failure pathogenesis. So we're looking at this in kidney disease because acylcarnitines rise with kidney disease, and we're showing that here. So we looked at data from the multi-ethnic study of atherosclerosis where they have systemic or metabolites measured in circulation. We looked at acylcarnitines specifically. There was 25 unique acylcarnitines. We looked at patients with CKD and without CKD, and you see 20 of the 25 acylcarnitines are elevated in patients with CKD compared to those without CKD. There is a graded response. As EGFR declines, acylcarnitine levels go up. Now, whether that is because of filtration or clearance, but we know these levels go up, and we know they're linked to heart failure in other studies. We looked at this in the combined study, and this isn't data that's fleshed out very well, but we looked at some levels of acylcarnitine in patients with chronic kidney disease, and we have measurements of left ventricular hypertrophy there, and we do show that there's some links between acylcarnitines and left ventricular hypertrophy in a population of chronic kidney disease. And so what we're really doing, and this is an ongoing study, and I'm going to show you some unpublished data here that show we're looking at systemic, we're measuring metabolites in circulation in chronic kidney disease, stages 2 to 4 in the chronic renal insufficiency cohort study. And we're looking at cardiovascular outcomes, including heart failure subtypes, ASCVD, peripheral artery disease, and echocardiographic variables. And I'll show you some very preliminary data here. So we have metabolites measured in 1,800 individuals. There's a total of 634 circulating metabolites measured. There's 25, once again, unique acylcarnitines. And these are just the acylcarnitines that are measured and some mean and median values for them. We're using lots of different statistical analysis when you do studies with metabolites. And so first we looked at per metabolite associations with heart failure, because that's the outcome that we are really interested in. And so we looked at all 25 acylcarnitines, and we looked at heart failure events, and we saw that 21 out of the 25 acylcarnitines are significantly associated with our outcome of heart failure. When you do multivariate modeling, we see some of these acylcarnitines flesh out to be associated with heart failure events. And I give you just one example. And this is modeling that adjusts for numerous covariates, medications, because we know that can affect acylcarnitines, adjustment for diabetes, because we know that can affect metabolism and metabolites as well. And we see that despite multivariate with multivariate adjustment, some acylcarnitines are still associated with our heart failure outcome. We then used other approaches like data reduction strategies, because we have large data sets with 600 metabolites and numerous outcomes, to see if there's anything that comes out that could provide to be potential important predictors of our outcome. So using Lasso regression, we saw that 11 of the acylcarnitines revealed to be potential predictors of heart failure events. And these acylcarnitines were consistent with our regression models where we did per metabolite analyses as well. So per metabolite analyses came out with a certain level or a certain number of acylcarnitines that were associated with heart failure. When we did Lasso regression, some of these same acylcarnitines came out to be associated or to be an important predictor of heart failure events. When we do principal component analyses, we're looking at all of these metabolites, we came up with 3 groups, group 1, 2, and 3. Group 3 are the ones that had the lowest EGFR but highest levels of all of these acylcarnitines. And we put these 3 groups into models. We see that the group that had the lowest EGFR and the highest level of all of these acylcarnitines and multivariate modeling was still associated with heart failure outcomes. So consistently, the same acylcarnitines are showing up to be associated with heart failure risk in patients with chronic kidney disease. So the current paradigm that we're looking at is in patients with chronic kidney disease, there's a reduction in glomerular filtration, tubular secretion, catabolism, gut microbiome, diet, all sorts of things. Remember, we're looking at accumulation of what is going on in our patients with chronic kidney disease at a specific time and point, but that leads to changes in the circulating metabolome, specifically acylcarnitines, that can then maybe lead to heart failure. And in the CRIC data, we're looking at adjudicated heart failure events, but in our patient-oriented studies, we actually want to look at preclinical heart failure, so patients who don't have heart failure at baseline. And so currently, we're conducting studies on this. I put this slide in here because this has to do with what our study is. There's some data that newer therapies like SGLT2 inhibitors can actually lower or change the metabolism. And so this is a very small study of 19 individuals. They had measured numerous metabolites, and they gave dapagliflozin for 12 weeks. And they showed that certain pathways and certain metabolites that were related to EGFR changed, but they also showed things like acylcarnitine and metabolites related to fatty acid oxidation decreased with SGLT2 inhibitors. There's data that ACE inhibitors also do the same thing, that ACE inhibitors can also change circulating metabolites, especially fatty acid metabolism metabolites as well. So kind of consistent data on things that improve kidney function over time, changing the metabolism. And so what we're doing now is that we're actually performing a study where we're recruiting patients with chronic kidney disease who don't have clinical heart failure, who have preserved ejection fraction, and we're measuring their baseline metabolites, and we're measuring their exercise testing, so we're putting them on a CPET, and we're getting 2D-STE, so we're looking at their cardiac mechanics, really looking at subclinical changes in the cardiac myocardium and changes with exercise that happen in patients with chronic kidney disease. We're going to give them an SGLT2 inhibitor for 6 months and remeasure metabolites and remeasure their 2D-STE and CPET. Really hypothesizing that there's alterations in the metabolites in our patients, there's subclinical changes in cardiac mechanics and functional capacity in our patient population, and that if you give them an SGLT2 inhibitor, you'll see changes in these metabolites, and these changes will be associated with changes in 2D-STE and changes in functional testing on exercise testing. So where are we right now? Oh, sorry. So this is actually one of our study coordinators who was doing a CPET study in Dr. Sanjeev Shah's cardiac physiology lab. And so on the right here, it's kind of hard to see, there's an echocardiography tester, tech, who's measuring, doing an echocardiogram at rest, during exercise, and then during recovery phase as well. And he's hooked up to a metabolic cart, so we're measuring gas exchange, we're measuring gas exchange and peak VO2 and exercise capacity at the same time. And so this is prior to the study starting. We kind of ran through this once with them. And so in the last year, we've screened 31 individuals from our CKD clinic. We've completed 20 baseline CPETs and 2D-STEs, where ongoing analyses are ongoing for subclinical HFpEF using the 2D-STE and CPET studies. And then our HFpEF2 protocol, the one that gives the SGLT2 inhibitor, was just approved. And so we'll be recruiting patients from our first study as well as into your clinics to again give them an SGLT2 inhibitor and see if we find changes. But there's lots of questions that remain, I think. What I want to emphasize as well is we don't do this to our patients with chronic kidney disease. We don't do functional testing very often in our patients with chronic kidney disease, and we probably underdiagnose HFpEF in this patient population. The other thing is all of these cohort studies, including the CRIC study, which is very well documented, numerous covariates, numerous echoes and MRIs, but we don't phenotype our kidney patients well. There's lots of missing data. And so the next step will be to do kind of integrated kidney phenotyping in this patient population with HFpEF or subclinical HFpEF, using blood, urine, imaging, and functional testing, which is probably one of the most important parameters, and really deciding, are all of our patients with CKD the same? Are they at the same risk for HFpEF? Is it truly just this renal pathophysiology? But we know our patients with kidney disease, some have diabetes and some don't. Some may have these other organ insults and some don't. So will they respond differently to treatments? Will they have different changes in their mechanics or functional testing? It'll be interesting to see that moving forward. So I want to thank my collaborators, primary mentor, Dr. Zakova, who's sitting in the back, Sanjeev Shah, who's a co-mentor on the K23, and the cardiac physiology lab that we do all of our functional testing and cardiac mechanics testing in, numerous, mentoring team members and collaborators, numerous study coordinators, Patrick, Alexis, and Maria, who have done a lot of the work in recruiting patients, which is not easy to recruit into clinical trials, and Shelley and Julia, who are not here, but a lot of their statistical support through them. So thank the Division of Nephrology and Dr. Quagan, Division of Cardiology as well, who we collaborate with extensively, the Center for Translational Metabolism, and then the funding sources as well. I want to thank you for your time, and I'm happy to take any questions. Dr. Quagan, yeah. Yeah, there's a lot of so this goes back to how we phenotype our patients, in these studies. And the truth is, we have lots of missing data. Even in CRIC, there's lots of missing data on proteinuria and when proteinuria is measured and all these things. So we don't have great data on that, actually. But I think it's part of what we're trying to do. Dr. Shah is, starting HeartShare, which is this HFpEF, international study or national study where they're recruiting patients with HFpEF and really trying to phenotype them. And they're phenotyping from other ways: cardiac phenotyping, functional testing, abdominal CTs. But really, I want to phenotype the kidney a little bit more, because there's so much missing data in our kidney disease population, and we just don't do these tests. But even things like UACR is missing. We think it's such a basic test for our patients, but the truth is, and we know this in primary care settings, even patients with diabetes or with heart failure, we don't measure UACR very well or accurately in these patient populations.
So, second question, the acylcarnitines is really interesting. Do you have any hypothesis how, blocking SGLT2 co-transporter in the phosphatidylcholine might?
Yeah. That's a great question, and nobody's, there's so many questions. The studies that have been done, and there's, like I said, there's like 1 to 2 studies that have looked at metabolomics and SGLT2 therapy, and there's lots of different proposed mechanisms and how this could happen, but there's no clear answer by any means.
And my final question was the phenotyping. Have you thought about including just collecting DNA without doing the genome, sequencing, but just it's very cheap to do it because it's more for the future?
I love that idea. I'm writing my R01 right now, so I'll add that to my, I think that's the next step, right? And I think, how do we phenotype our kidney patients? And, that'll be, that's a great thought to be part of it. Shika says Dr. Batier. So. Thanks, Dr. Batier. No, so we adjust for, you bring up a very valid point. Hypertension is a huge comorbidity, a huge risk factor for both of these things, but we adjust for hypertension in numerous ways, not just the presence of hypertension. We adjust, this is all statistical modeling though, right? So there's caveats to all of this, but we adjust for hypertension, we adjust for systolic blood pressure, we adjust for number of blood pressure medications, because that has to do with resistant hypertension and, whether you're controlled just having no or one medication versus 4 medications makes a difference. So we control in every way possible in the statistical modeling for this. But you're right. I mean, hypertension, but we know as CKD progresses, hypertension gets worse. We know as cardiovascular disease progresses, hypertension gets worse. And so it's likely linked to all of these things. When we talk about HFpEF subphenotypes, that systemic vascular phenotype is the phenotype of arterial hypertension, recognizing that arterial stiffness and hypertension is a huge risk factor for heart failure with preserved ejection fraction development. And that's also why I said the patients with CKD don't just have this renal phenotype of venous congestion and volume overload. They have all of these other phenotypes as well. They have the obesity phenotype, the obesity diabetes phenotype or metabolic phenotype. They have the systemic arterial hypertension phenotype, which is probably why even the CKD phenotype of HFpEF is very heterogeneous. It's probably not all the same either, which I think is even more reason to kind of subphenotype the CKD phenotype. Shaka.
Great, inspiring talk, Rupal, as always. I have a sort of big picture question. Looking back to some of your earlier slides when you talked about UACR being one of the greatest risk factors for heart failure, have we looked at if we are able to reduce proteinuria or albuminuria with ACE inhibitors, or in my population of patients, getting them into remission of their coronary disease, which is not the population studied in Frank and others, but does that attenuate heart failure risk? Do we know that, I'm thinking to the KFRE equation, when you go into kidneyriskfailure.com and, we show that here's what your predicted risk is. And if you, take a ACE inhibitor, you can reduce your risk this much. If you add an HFpEF inhibitor, you can reduce your 5-year risk this much. Do we know that about heart failure risk?
Yeah, so I think, a lot of this idea of like reducing proteinuria, and we reduce it with ACE and ARBs, right? And ACEs and ARBs have been shown to reduce heart failure risk in heart failure with reduced ejection fraction, but not heart failure with preserved ejection fraction. And I'm not saying that's because we are or we're not reducing proteinuria, but I think they think the mechanism of that is in HFrEF, we have neurohormonal activation. That seems like the primary driver of HFrEF, along with myocardial ischemia, but then you get this activation of the sympathetic nervous system. And so when you block that with RAS, we can then prevent heart failure admissions and heart failure progression, or even attenuate LVH. On the HFpEF side, that data is not there, and it's quite inconsistent. And it's probably because the driving factor is not just sympathetic activation and neurohormonal activation. There's actually been studies done where they've measured neurohormonal peptides, and all of these things are quite low in HFpEF. And so we haven't had the same success with therapies for HFpEF than HFrEF. Now, I'm kind of indirectly answering your question, which is, if you reduce proteinuria, can you reduce HFpEF? But the truth is, there's no unifying diagnosis of HFpEF, and all of the studies of HFpEF outcomes, there's just not great data on this, because it's so hard to make a unifying diagnosis of HFpEF outside of just ejection fraction. And I think that's where the next steps are going to lead. And then in these studies, in earlier studies, CKD patients were excluded, and UACR was definitely not measured, right? And so that's the other problem there. Yeah.
Thank you very much. Question is pediatricians, we don't really see a lot of heart failure in patients with CKD, and you brought your attention to something we talked about in patient. What's known of the younger, young adults in that context? And is there any component of time to that adult disease where the development of this topic?
You're bringing up a fantastic question. I'll be honest, I don't know the answer. Nisha Bansal has looked a little bit of in the younger population of crick. So not pediatric patients, but on, I think it's like 18 to 30, and did show some differences in that age group compared to the others. But remember, these are all patients with chronic kidney disease and some sort of hypertension, probably at least. Alex Kulas in your division is really studying or trying to study kind of heart failure and cardiovascular risk in your patient population, looking at really some of the same stuff, looking at left ventricular hypertrophy and changes in cardiac findings in this pediatric population. I think it's really, really important to study, and I think he'll be very successful in studying that. And so So we're actually trying to collaborate. So Alex and I are collaborating to get our IRB approved at Lurie's right now, which actually I think is going to panel, as Patrick says, today, to see if we could recruit some of that 18 to 20 to 25-year-old patient population into our study, who would then get functional testing, 2D STE, and we could maybe enroll into the second part of the study as well. Dr. Pagan.
So you mentioned the UACR, and you made the point that this might be because of microvascular disease. I think that makes a lot of sense. So how well documented is microvascular disease causing HFpEF? So, thinking to shift this question, it may be that reducing proteinuria in and of itself, if it's not impacting microvascular disease,
Yeah.
it's not. It's just really a surrogate.
Yeah, I think that's the great point, and so you're absolutely right. So that most people do not believe proteinuria is causally or directly related to it. It's more of a surrogate marker of maybe microvascular disease. But all of this is kind of like hypothesis, this idea that UACR is just a marker of systemic endovascular disease. Now, how do you measure systemic endovascular disease, and has that been kind of teased out? It probably has not. But there is this idea that systemic inflammation and microvascular disease lead to HFpEF. But it's just one of these kind of, as part of this sub-phenotyping group, that this is kind of maybe the cause of it. They, they do have, there's very few data on this, but there's some small studies where they've done myocardial biopsies and seen evidence of microvascular disease in the HFpEF population. I think Sanjeev had a smaller study where patients were willing to do that. But you have to remember, it's really hard to recruit patients to do right heart catheterizations and myocardial biopsies for research purposes. Okay.